Okay. So good evening, everybody, and welcome to the CAHO Quality Education Series. And today is the 30th of this program. We have been doing it continuously for the past 2 years now, and this is being conducted every month. I am Dr. Anuradha Pichmani, OBGYN consultant and the Executive Director of Sriranga Hospital, chairperson of the Quality Professionals Wing of CAHO. And to introduce CAHO to the new participants, CAHO is a non-profit organization dedicated to promoting safer patient care, strengthening quality, and promoting accreditation. And CAHO is also an institutional member of ISQA, the International Society for Quality, and the Asian Society for Quality. So under CAHO, we have three verticals. One is the healthcare institutions, the second is the diagnostic centers, and the quality professionals. And this is a collective group, and we are trying to collaborate and pool all the resources to achieve the shared goals to enhance the quality of healthcare services. And CAHO's vision is to be an admired global leader, transforming healthcare quality and patient safety. So moving on, I would like to introduce you to the CAHO dynamic leadership. We have President Dr. Vijay Agarwal. We have the Vice President Dr. Shankar Sen-Gupta from Calcutta. We have Dr. Lalu Joseph, who is the Secretary General of CAHO, and the Finance Secretary is Dr. Nareen Sehgal. So CAHO has been promoting various structured training programs aimed at the grassroots level of healthcare workers. We have trained more than 10,000 clinical and non-clinical healthcare professionals up to date. We have these various programs and various quality education series, quality diagnostic series, various masterclass, which you can go through the website. CAHO's website has all of this. And for today's program, it's being organized by the CAHO Quality Professional Wing. And to introduce the wing, we have the Vice Chair, Dr. Suvin Shetty from Bombay. And we have the Secretary, Dr. Anna George from Aster, India. And we have a huge member group in this Quality Professional Wing again. And I would like to welcome all our partners for this 30th Country Quality Education Series. I welcome and thank the President of ASQA and all the board members of ASQA for their collaboration with CAHO in this continuing quality education. Again, we are very privileged to have SEMI, the Society for Emergency Medicine India, as the knowledge partner for this program. And we welcome the President and the members of SEMI for this program. To introduce this webinar, this is a 3-hour virtual conclave conducted every month on the each session is led by 4 or 5 experts with extensive domain knowledge and experience. And we are trying to learn from them. And these sessions are aimed at educating healthcare workers across India and even outside India now. So on behalf of the governing committee of CAHO, I welcome each and every one of you and look forward to a very engaging session from all these speakers. And the theme for today's session is patient safety in emergency department and pre-hospital services. And this 3-hour session has been put together by a wonderful group. We have the organizing team, and I'm very happy to introduce the organizing chairperson for today's webinar, Dr. Sarana Kumar. So he's an emergency medicine specialist by training and currently the group unit head of Dr. Mehta's Hospital in Chennai. He's the national president of the Society for Emergency Medicine India and the chair of the Quality and Patient Safety Special Interest Group from the International Federation of Emergency Medicine. He has a special interest in improving quality systems in healthcare, and he was awarded the Young Quality Champion by CAHO in 2019 for his work with the organizations like AHPI and the ISRO, the Indian Space Research Organization, in drafting various quality standards for emergency department. I now request the organizing chairperson, Dr. Sarana Kumar, to introduce his team and take the proceedings forward. Over to you.
Thank you very much, madam. Can you hear me?
Yeah.
Thanks a lot. And first and foremost, my sincere thanks to the CAHO leadership, the President Vijay Agarwal sir, Secretary Lalu ma'am, and all the CQP organizers today, Dr. Anu ma'am, Dr. Suvin, Dr. Anna. Thanks for giving us this opportunity. And this wonderful program is because of all of you. A little bit about SEMI, Society for Emergency Medicine India was founded in 1999. And since last 26 years, we've been actively involved in promoting the specialty of emergency medicine in India and also educating and upskilling all our members in various fields or aspects to emergency medicine and beyond. One of that areas for us is quality and patient safety in emergency department. And I'm extremely happy to say SEMI and CAHO has partnered in many such initiatives previously also. And some of those noteworthy ones are our collaboration with ISRO in drafting the quality standards for the country. We also have, through CAHO, a disaster life support program introduced almost 5 to 6 years back. So our association with CAHO has been a long-standing one, and thank you, CAHO, for giving us so much of learnings and takeaways and best practices in quality and patient safety, which now is being implemented across different parts of the country in various emergency departments. Personally, also, I gained my quality knowledge from CAHO, and thanks to many wonderful teachers and quality experts of CAHO, like Madam Lallu was my first teacher in quality. Also, Mr. Samir Mehta, the former vice president of CAHO, also happens to be my mentor, who introduced me to CAHO first. And from then on, we ensured that most of our members are also part of CAHO programs and seminars to upskill themselves in the knowledge of quality. Today, we got a wonderful set of speakers from various parts of the country. Some of the best speakers you could find in quality and patient safety and emergency departments. They have come out with a very interesting set of topics on managing, monitoring quality and ensuring patient safety, right from pre-hospital care, in hospitals, access blocks, communication or the importance of communication or ED, and also using latest technologies like VR, etc., in improving patient safety. So it's going to be quite an interesting and a different session compared to any other sessions you might have experienced before. I can assure you that. It's also my pleasure to introduce two of my key members or partners in today's event. One is the secretary for today's event, Dr. T.R. Srinath Kumar. He is the group quality head for the Sparsh Group of Hospitals in Bangalore. He is also the academic chair for Society for Emergency Medicine India and a good friend. Thank you, Dr. Srinath, for joining us today, and he's going to be moderating a very important panel. And let me also introduce my moderator for today, good friend of mine, Dr. Abdul, who is a senior manager of nursing operations and quality and corporate functions at Healthcare Global Enterprises Limited, Bangalore, India. He's also the GC member of CAHO and also a faculty for various programs of CAHO, and also happens to be an Young Quality Achiever Awardee of CAHO in 2024. So he's going to be moderating this session. And I think with that, thank you all once again for joining, and thanks CAHO for giving us this opportunity to collaborate. I'll pass it on to Abdul, my moderator for today. Abdul, over to you.
Thank you, Dr. Salona. Very good afternoon to all. It's wonderful to have you all today connected with for our emergency program or emergency department program with the theme of patient safety in emergency department and pre-hospital services. So with no further delay, we, as Dr. Sarvana was rightly saying, we have an eminent panel of speakers here who will be taking you through a lot of knowledge, lots and lots of knowledge. Obviously, there'll be a lot of QA session also. Please kindly post your questions in QA chat box so that we'll be able to answer. Faculties would be readily, answering your questions. Along with that, please keep your mics on mute so that you don't disturb the speaker when they are on the floor. So to initiate and to kickstart with our first speaker of the day and for the program, we have Dr. Sudeshna Ganguly, who is a medical director, Indian subcontinent, Telagdo Health International, and Madam is also director and co-founder of Razack Pain and Polyclinic, Newtown, Kolkata. Along with that, she is also associated with multiple organizations. She is also an NABH assessor, and she's also an examiner for MEM UK. So over to you, ma'am, for this wonderful session.
And thank you, Mr. Abdul, for that wonderful introduction. I take this opportunity to thank CAHO and SEMI for organizing such an impactful session. Our topic for discussion today is mitigating quality challenges during mass casualty and outbreaks. I will take you through this topic on the following headings. We will start with a brief introduction and definitions, followed by delving into the challenges faced by the healthcare system, methods to mitigate those challenges, and a quick look at the quality indicators. I will end by presenting to you a case study where a major MCI event was actually averted, and we will see what are the points that were so interesting or so factual in saving lives. Because that's what we do as an emergency physician. I think our primary aim is to save lives, and hence that would be the ending point of this discussion. So before we go any further, let us look at some of the terms that we are going to use through this presentation and understand the implications and importance of them. So first point is, what is a disaster? A disaster is a natural or human-made or technological hazard resulting in an event of substantial extent, causing significant physical damage or destruction with loss of life or drastic change to the environment. A disaster is an event that results in a demand for services that exceeds available resources. So this is the first take-home message from this presentation. There is a gross demand-supply mismatch. So we can say in a way that this is the first challenge which is inherent in the definition of this particular term. This is a photograph which shows the Uttarakhand flood situation. And you can only imagine the amount of rehabilitative and resuscitative efforts that would be needed to put the society back on its feet. What is a mass casualty or a mass casualty incident, as it is better referred to as? So an MCI is defined as an event which generates more patients at one time than locally available resources can manage using routine procedures. It requires exceptional emergency arrangements and additional or extraordinary assistance. So this is the second take-home message, that it requires exceptional or extraordinary assistance in order to get over an incident of this nature. I have a graphic here. This is the Coromandel train accident, and you can imagine the surge of patients that are going to come out from an event of this scale and nature. Going to outbreaks. An outbreak is a sudden occurrence of a disease in a community which has either never experienced the disease before, or when cases of that disease occur in numbers greater than expected within a defined area. Human history has been dotted by multiple such outbreaks, but the nearest in memory happens to be SARS-CoV-2, which hit globally in the years 2020 to 2022. And this graphic is one of the very many known pictures where we can have an idea from this picture that how our resources must have been strained and the challenges faced by the healthcare community and the healthcare system and a society as a whole when an incident of this scale unfolds. So with that, I will go into the challenges that we face. I think by the sheer definitions of the events that I've just outlined, we can more or less understand what the challenges are likely going to be. So let's look deeper. The challenges to quality healthcare that are presented by an MCI or outbreak fall under primarily four headings. First is resource shortages, where we have limited supplies, staff, equipment. Almost everything is lesser than the demand that's being placed on it. Next is increased patient load. There is a surge of an overwhelming number of patients that tend to strain and drain out the healthcare system very fast. The third challenge is infection control. There are significant difficulties in preventing cross-contamination, and this involves a significant outlay of staff and almost 24/7 coverage in order to simply prevent any further disasters from happening due to cross-contamination. The fourth pillar is communication breakdown. I cannot but emphasize further on this. Issues in communication and coordination among healthcare providers is of paramount importance, again, in order to avert further disasters, and we will see how. So the first point is resource shortage. As I said, that almost everything is short as compared to the demand that is placed on it. So there is an acute shortage of staff. When I say staff, I mean staff of various groups and categories, including doctors, nurses, technicians, paramedics, housekeeping, security, administrative personnel. Almost every segment of short is severely strained when we are overwhelmed by an MCI or outbreak. There is also, in addition to this, a shortage of specialized personnel. Depending a little bit on what you are looking at, there are specialized staff who are needed. For instance, if I go back to the outbreak that happened very close in memory, as I said, in SARS-CoV-2, there was a sudden demand placed on respiratory specialists, on chest physicians, intensivists, who would have the capacity and inherent knowledge to manage a condition of this sort. Now, it is very difficult to have specialists come up overnight. So that is one very, very significant area where we are sort of really on a back foot when it comes to an incident of this sort. Next is shortage of supplies, consumables, including most importantly medications, which can result in significant challenge to the quality of healthcare that we deliver. Shortage of equipment. I think we all have quite fresh memories of nightmarish events unfolding when we actually fell short of oxygen, when we fell short of respiratory care equipment, when we fell short of ventilators. Shortage of space. Very poignant graphics have made the round during the global pandemic, where we found that patients are being treated literally under the open skies because you do not have any other space to accommodate your patients. Alongside comes shortage of food, clean water supplies, electricity. So the entire infrastructure is severely strained when we have an MCI or outbreak happening. Coupled with this resource shortage, we have increased demand. This increased demand is not only in terms of increased number of patients overwhelming your healthcare facility. What we have here are multiple categories of patients that need to be triaged, assessed, managed, disposed simultaneously. I'm not sure about the exact division of the attendees who are sort of listening into us, but I'm sure there would be emergency physicians, and most of us these days are, sort of acquainted with triage. It's sort of just sorting out the patients with respect to their intensity of the problems. So with respect to an event of this scale, we basically tend to very quickly triage between those who are Black, that's peri-terminal or deceased, those who are in the red zone, they require immediate care, those in the yellow zone who might give you some time, and the walking wounded who fall under green. Now, the problem is all four categories will come to you together. So it requires intensive focus by a staff who are already overwhelmed to triage, assess, and manage these patients all at the same time. There are also a large number of procedures that are to be performed within a very short span of time. Almost your entire yellow and red group would be requiring some procedure or the other at some point in time, and that would again strain your supplies as well as your staff. Coupled with that, this is a situation which poses medical, ethical, cultural, psychological, and legal challenges. When you're taking a decision in triage, we need to remember that we are affecting human lives. And the law of the land, your cultural, moral, ethical responsibilities, and your medical expertise are put to test like never before. So this is the second very important challenge that is posed to the healthcare community when we are facing an outbreak or a mass casualty incident. Now, infection control. This is something which is always relevant. You cannot do without it. But the degree, impact, and relevance and involvement of infection control depends a little bit on the nature of the incident or outbreak. For instance, when we are dealing with an infectious outbreak, then obviously infection control goes just beyond the realm of being a support service, and it comes into the center of patient care management. Again, as I said, infection control coverage is needed round the clock. Another important point to remember is that unlike your usual infection control, you are now no longer going to deal with just your central hospital. You're also going to deal with a number of extended care facilities that you might have set up, which includes your respondents on site, which includes your field hospital, which includes your shelters, which include your holding units. All of them will require infection control, if you do not want another disaster in the making, that is. So there are various points that come under this. This is, of course, not an exhaustive list, but since the focus here is on mitigating challenges I've just touched over, we know that infection control figures in terms of screening and triaging, hand hygiene, specimen handling, formite control, patient decontamination, PPEs, waste management, managing and cleaning, disinfecting the patient care areas, isolation procedures, respiratory etiquettes, rounding off with even postmortem care. Next, we come to the fourth pillar of challenge, that is communication breakdown. Communication breakdown is a major, major challenge. There is a need for communication channels to work between various responder and provider groups. Intersegmental communication between healthcare personnel and clinical and support departments is very essential. Emergency needs to communicate with radiology. It needs to communicate with OR. It needs to communicate with the supply chain. We need to communicate intersegmentally between various healthcare provider groups. We need to communicate with the responders, the first responders who are on site. We need to communicate with EMS who's bringing in the patient. I mean, we are communicating multiple channels simultaneously with various sets of communication. And most importantly, we are communicating with significant outsiders. Possibly I should not use the term outsider, but the word significant sort of mitigates for it. And when I say outsiders, I mean the anxious outsiders who are there waiting for news for their near and dear ones. So we need to communicate with the general population, with the police, press, and other community-based agencies which typically respond in such situations. Because we would want to avoid something like this. This is a typical breakdown scenario of communication where you have an entire, mob of people out there who are looking for a significant amount of accurate information and probably not getting it. Before we move on, I would like to show you a case study of what happened or what can happen when communication channels break down. We are looking back in history to 2001, but I think the memory of this is quite fresh. We changed the coastline for the east coast of US almost forever, and the Twin Towers got attacked. The entire east coast of a country like United States of America was completely jammed. Communication broke down totally, and many firefighters lost their lives when the Twin Towers collapsed. That is because they did not get the information or the intimation that NYPD was trying to convey to them. So that's how important communication is, and that's how big a challenge it is. So as I said, we cannot perpetuate another disaster from the disaster that's already in the making. So just to summarize on the points in terms of challenges so that we can understand the mitigating strategies a little bit better. So first and foremost, triage and prioritization. It can be very difficult to make rapid decisions about patient care, keeping in mind the ethical and moral responsibilities that we have as healthcare providers. There is a huge infrastructure strain as your physical and technological infrastructure will get overloaded. There is a huge psychological impact that occurs not only to the victims of the incident, but also to the responders, right from the frontline healthcare workers to the ones that are working in field hospitals, shelters, in your main hospital. Everybody faces a huge psychological impact. And none to say the ethical dilemmas of balancing limited resources with patient needs. So with this in background, I go to the mitigating strategies and what we can do in terms of reducing the impact of such incidents on the healthcare in a system and on the entire society as a whole. So the strategies of mitigating the quality challenges in delivery of healthcare also come under 4 main headings. First is preparedness and planning. Developing emergency preparedness plans, contingency planning, preparedness. I cannot but overemphasize on this. Hand in hand with this goes training. And that training and upskilling, knowledge building, sharing, capacity building has to happen continuously in the form of simulations, drills, training, where we try and replicate the environment as far and as practically as possible. Next is one typical area which tends to be pretty shrouded and away from, our common, let's say, focus, and that is supply chain management. While this entirely might not be within the ambit of healthcare workers, but nonetheless, we have contributions to make, and I will explain how in my next few slides, in ensuring that adequate supplies are maintained through better logistic management. And last but not the least, again, communication. We need to establish protocols for clear communication channels. We might not be the ones that are working in the hardware part of things, but we need to have a proper method of communication established, which we can utilize at the time when the strain is placed on it. So from here, we go to preparedness. Before I go into how we prepare for it, or at least the outline of it, various studies and the research that's been done in this field has very definitively shown that many lives can actually be saved if the communities are better prepared, with an organized and scalable response system already in place. In addition, survivors of a mass casualty incident often suffer disabilities or healthcare impairment that's both physical as well as psychological, and that can severely strain the healthcare system, not only at the time of when the incident hits us, but also far beyond it. I think all of us can see effects of COVID all around us till date. Much of this is again avoidable depending upon the preparedness, resilience, and strength that we develop as a community overall. In lieu of this, in September 2006, a global consultation on mass casualty management was held in Geneva at the WHO headquarters. And this resulted in the WHO developing mass casualty systems and programs. What every community needs to do, the first mitigation strategy for dealing with the healthcare challenges that are placed on us when we are facing such an incident, is to develop programs for mass casualty and outbreak preparedness, keeping in perspective the unique geographical, demographic, cultural, and risk factors that your specific community faces. If we are a community that's within a seismic zone, we need to prepare for potential earthquakes. If we are in a flood-prone area and we know that there are certain months of the year where we are going to get flooded, it is but common sense that we prepare contingencies for it. If we are a community that is close to, say, a nuclear plant, we should be prepared for possible or potential nuclear disasters. If we are unfortunately in an area that is plagued by psychosocial unrest or in, say, terrorism, then we need to be prepared for that. Look for local capacity and knowledge building, which needs to happen on a continuous basis. So let's look at what can be an outline for emergency planning. Here I'm
Doctor,
not
you have
going
last
to...
3 minutes of yours. I'm sorry to bother.
Okay.
You have last 3 minutes of yours, yeah.
Then possibly I'll have to skip quite a bit. But anyways, so we can define a project, plan a group, analyze potential problems, analyze the resources that we have. The roles and responsibilities have to be put out there, and we develop strategies. So this is basically a disaster management cycle that needs to be in place, where we are preparing, then responding, recovery and mitigation phases. How well we respond depends on our preparation and mitigation phases. Important agencies that work on this front in India, just to sort of highlight for the benefit of the participants, we have National Disaster Management Authority at the apex. The NSC is a branch which actually lays down the game plan at the basic level. The state disaster and the district disaster management authorities, along with local authorities, actually put these plans into action. Training, again, is something which is very, very important, and experience has shown that we need to train an entire community and not just the healthcare workers. So if we are able to build capacity at the human and organizational levels at the community, then we can empower the communities to develop emergency management plans for mass casualty incidents, and that can really result in a very strong response coming not only from health authorities, but also from various support sectors. Supply chain management, as I said, it's very, very important. And I would draw your attention to this point, which definitely needs to be highlighted. Monitor your events, predict them, forecasting, stockpiling, depending on this forecasting, contingency planning with logistic capacity assessment. That results in improved search and rescue, needs assessment, and a quick demand to supply time. We need to reduce the demand to response time, and that is what your preparation will help you do. So a proactive approach needs to be developed to build in capacity during the best of times so that we can mitigate challenges during the worst of times. Build the supply chain capacity through careful consideration and preparation, make efforts to reduce the request to delivery time, and also fortify your humanitarian cargo chain. Building communication channels is very, very important. It's worthwhile to remember that during MCIs and outbreaks, all your conventional channels might be down. So you need to have a planning in place of what other alternatives can you have for mass media communication. And of course, protocols for intersegmental and interdepartmental communications need to be in place. I cannot do away with this. One of my favorite authors and literary figures, Sir George Bernard Shaw, had centuries ago had said, or maybe I should say decades ago had said, that the single biggest problem in communication is the illusion that it has taken place. So let us not be under an illusion that we've communicated, and ensure that we actually communicate through proper and accurate delivery in a timely and concise manner, because communication can save lives. Proactive steps need to be taken to set up and maintain means of communication that can be used during incidents. Responder groups must also be well trained in communication protocols, so we know exactly how much information we need to give out and in what format it needs to be given out, so that we neither overwhelm the communication channels, nor do we have any communication that needs to be done being left behind. The quality indicators, there are some quality indicators that we look for during mass casualty incidents. Triage efficacy, that's effectiveness of the triage systems in prioritizing care, how well that has worked, we need to assess. Survival rates, that's number of critically injured patients we were able to save. Resource utilization percentages, efficiency in utilization of available resources. And last but not the least, an often neglected area, staff well-being, monitoring the mental and physical health of healthcare workers. Very, very important. Quality indicators that are important during outbreaks include, again, morbidity and mortality rates, infection rates, patient satisfactions, and the response time or the speed of response to emergency situations. There are certain recent developments in quality indicators that have taken place. AI has obviously come in, and AI-induced monitoring of real-time data with real-time data tracking and better decision-making. So these two sort of go hand in hand. And we cannot but ignore the role of technology in telemedicine and expanding the use of telehealth services during crisis. I think we saw an ample evidence of this as the telemedicine guidelines in India came into force during COVID almost overnight. So, of course, technology needs to be leveraged in a big way. Global health collaborations and partnership and sharing resources and best practices. The NDMA is also working for this, and they have over the decades changed their reactive approach to proactive, which is great news for our nation. Future directions include innovation in healthcare with emphasis on new technologies and practices. Policy and regulations are very important. The government happens to be a very, very significant stakeholder. And without government support, we cannot possibly develop sustainable strategies to mitigate the quality challenges faced by healthcare systems during such events. Continuous improvement on the ongoing training and development for healthcare providers is of paramount importance. I had a case study here, which I really wanted to highlight. Japan often is quoted as, being a community that has stood out in terms of their quality and resilience. There was an accident which actually could have claimed as many as 379 lives. And this is not something which has happened long back. This has happened in January of 2024, this very year at the beginning. Incidentally, Japan was also a country which had faced the worst aviation disaster ever in the year 1985 when they lost almost their entire crew and all passengers on a plane that burst into flames. But it is evident that they have learned their lesson. So all 379 passengers and crew escaped relatively unscathed after a Japan Airlines Flight 516 burst into flames following a crash with a Coast Guard plane on Tokyo's Haneda Airport. The Airbus A350 jet was able to evacuate all their passengers in a record of 20 minutes. Do I have time for playing a video that's there on it? Maybe not.
Probably, Doctor, we will be able to share it to them because we are pressed with time.
Yeah. So what I wanted to emphasize here was that the best mitigation strategy for an MCI is how to avoid it. So nothing can go over preparation and prevention, and preparedness is the key here. And it is very, very important for us as a community to develop capacity and build our knowledge base in terms of these incidents. So developing good communication channels, fortifying our supply chain, ensuring training, and developing preparedness is what is required, so that we do not save lives after the incident, but we can also prevent an incident from scaling up and from actually claiming lives before we can step in and do it. So I think with that, I do run out my time and I actually rest my case, as they say. So I stop share here.
Thank you so much. Thank you so much for that wonderful discussion. I'm sure that we are pressed with time, so we had to little push you down. I'm really sorry for that.
Right.
So thank you so much, Doctor. It was a wonderful deliberation. I'm sure that the entire participants have understood the importance of mitigation and quality challenges during outbreaks along. Thank you so much for your time.